Hello, Christy Bishop here for the Canadian Society of Respiratory Therapists, giving you some more information on Mechanical Ventilation Basics Part 2. In this information session today, we're going to look at initial ventilator settings and some different modes of ventilation for our patients. So one of the very first settings you're going to use is tidal volume, one of the more important settings. So initial tidal volume settings are related to ideal body weight, and typically for adults we're looking at anywhere between 6 to 8 milliliters per kilogram of volume for adults, and then around 4 to 8 milliliters per kilogram of ideal body weight for infants and children. And really the goal is to keep alveolar pressure below 30 centimeters of water. So that's your plateau pressure, and we want to make sure that that is below that level to avoid overdistension and having volutrauma and barotrauma. Tidal volumes of greater than 10 mils per kilogram are really not recommended because we're getting into that range of overdistending our lungs. We're really increasing our risk of overdistension. And we need to remember that as lung compliance decreases, we have to modify our tidal volume to kilogram requirements. So we're going more on that lower end. And if you're looking at different protocols like the ARDS protocol, we can go as low as 4 milliliters per kilogram of ideal body weight. Now, we have to remember what are the components really of tidal volume, and we need to understand that it's comprised of both dead space volume and alveolar volume. And when we get into those really low tidal volumes of less than 4 mils per kilogram, then we're not having much alveolar ventilation at all. We're really just ventilating dead space. Our normal physiologic dead space is around 2.2 milligrams per kilogram of ideal body weight, and that's going to increase once we place a patient on mechanical ventilation. So we really want to avoid super low tidal volumes, so nothing lower than 4 milliliters per kilogram. Another component that you're going to set is respiratory rate and really minute ventilation. So determining our tidal volume is easy. We have a good milliliter per kilogram normal ratio that we'd like to use, right? We want to use somewhere in around those 6 mils per kilogram range. So how do we set our respiratory rate? What's the best way to set our respiratory rate? And we can do that based on our minute ventilation. Now, minute ventilation is difficult to target, and respiratory rate is difficult to target as well. A normal minute ventilation is somewhere in the 4 to 8 liter per minute range. If you have a patient's body surface area, so if you have their height and weight and you can determine their body surface area, that's even better. So a really good starting minute ventilation for males is their body surface area times 4, and for females it's their body surface area times 3.5. But we don't always have that information or accurate representations of that information. So somewhere in a normal 4 to 8 liters per minute range is good for your patients with a sort of normal metabolic status. You need to understand that these values represent a minimum sort of setting guidelines for minute ventilation and respiratory rate. Their pathology, their underlying pathology always must be considered. If you have a patient in a diabetic ketoacidosis, then chances are you're going to have a higher respiratory rate and a higher minute ventilation because their metabolic condition is going to dictate that. If somebody has a fever, right, their oxygen consumption increases and their CO2 production increases, and we need to increase their minute ventilation appropriately to compensate and to rid the CO2 and to get enough oxygen as required. So having a minute ventilation targeted around 4 to 8 liters per minute and a respiratory rate somewhere between 12 and 20 breaths per minute, again, that's just a basic guideline if everything was normal and great, but chances are you're not going to ventilate a normal patient, right? We're not ventilating patients who have normal conditions. They have some sort of underlying pathophysiology. So we need to take that into consideration and really let the patient's blood gas dictate the settings that we use for respiratory rate and minute ventilation. When we're looking at flow or I time, they're very much related to one another. In some ventilators and in some modes of ventilation, you're going to set flow, and in others, you're going to set I time. And really the goal is to get the flow into the patient in the shortest period of time possible. So we want a really fast, well, not a really fast, but we want a fast I time to achieve an I-to-E ratio of somewhere around 1 to 1.5 or less. So 1 to 3 and 1 to 4 is ideal. And typical flows, I time, so a flow of anywhere between 40 to 80 liters per minute is considered sort of normal. An I time of somewhere between 0.8 to 1.2 seconds, again, in that normal range to have a nice maybe 1 to 3, 1 to 4 ratio. You should be noted that you may have to match the flow demands of the patient if they're triggering or breathing on their own or assisting the breathing. So if a patient looks like they're flow hungry, then we may have to increase the amount of flow that we're giving the patient because we don't want them to work harder. So the sort of relationship we see between flow and I time is a faster flow usually equates to that shorter I time, because flow is just a representation of volume over time, and if we want to get that volume in quicker, then we're going to need a faster flow to do that. Faster flows are associated with higher peak pressures and a bit poor gas distribution, but it may be beneficial for patients who have increased airway resistance. They may like that higher flow to get the air in faster to overcome that resistance, to help overcome the resistance. Slower flows have been shown to improve gas distribution in the non-homogeneous lungs, so patients with ARDS. You do get lower peak pressures with lower flows, but they may also increase your mean airway pressure, and a lower flow may lead to air trapping. That's the whole goal. So we want to get the gas in quick enough so that we have a long enough long enough expiratory time, so that we are avoiding air trapping. That's the whole goal here, and the best way to achieve that is to have a shorter I time. So the goal is to get the air in as fast as we can within reason to maintain a nice normalish I to E ratio and to have enough time for exhalation. Now the selection of FiO2, the best way to choose which FiO2 to use would be if we had a baseline blood gas. So if we have a baseline blood gas, then we can use that PaO2 and our FiO2 ratio to titrate to a desired value. There's a formula on here. So we have our known PaO2 here from our blood gas, and we have our known FiO2 from our blood gas, and then we can titrate that by knowing what we want our PaO2 to be, so our desired PaO2, and we can determine what the FiO2 would be required to have that desired PaO2. If a blood gas is not available, really it's best to select a higher than normal FiO2. So if the patient's already on 40 or 50%, then maybe you're going to start them there and use that as your starting point. If they're on 100%, start them there and use that as your starting point. And you're really going to titrate your FiO2 based on your blood gas. It's the best way to do that. And if there's no blood gas available, remember that you always have an SpO2 monitor on your patient, and that should be available to you, and titrate based on your SpO2. Be wary of low perfusion states though. Remember, there are some limitations to the SpO2 monitor itself. So if somebody has poor perfusion, then their SpO2 reading may not be as accurate. PEEP and CPAP, really the goal of PEEP and CPAP is to enhance tissue oxygenation and maintain a PaO2 of greater than or equal to 60 millimeters of mercury, so somewhere in around that SpO2 of 90% range if everything's nice and good. So with PEEP, most of our patients are going to be on normal levels of PEEP, so somewhere in that 3 to 5 centimeters of water pressure range. That's our normal physiologic PEEP. We're replacing what's lost due to bypassing the upper airway and being placed supine on our back to help overcome some increasing pleural pressures. So it's really important that we have the appropriate amount of PEEP set. We want to avoid overdistension, but we also need to prevent alveolar collapse. during exhalation of normal tidal volume. So we don't want to keep opening and closing the alveoli on every breath and causing atelectatic trauma. So we need to make sure that we have an appropriate level of PEEP. Most of your patients, if there's no wildly difficult underlying pathology, having minimum PEEP of 3 to 5 centimeters of water pressure will be enough. However, there is time if your patients are starting to develop some refractory hypoxemia caused by some sort of intrapulmonary shunting due to a decrease in your functional residual capacity or reduced lung compliance, therapeutic PEEP may need to be applied, and this would be PEEP of levels of greater than 5 centimeters of water pressure, or very, very high, up greater than 15 centimeters of water pressure. But this would have to be determined based on the patient's underlying pathophysiology, and you would want to go through and check and make sure that you're using the appropriate level of PEEP. We're using this to treat shunt and VQ mismatch, and the best way to do this is to do a PEEP study, whether it's a decremental PEEP study or an optimum PEEP study, whichever kind of PEEP study you can get your hands on. So if a patient's oxygen requirements are increasing, if they're having this refractory hypoxemia, and we need to increase our levels of PEEP, then we should be investigating and making sure that we're setting at the appropriate levels so that we're not overdistending the alveoli, but we're also not collapsing the alveoli on every breath. Sensitivity setting. So our sensitivity usually refers to how a patient triggers a breath, whether it's pressure or flow. And whatever setting we're using, whether it's pressure or flow, the patient must generate that amount of a set trigger. So for example, if you have a flow trigger and it's set to 2 liters per minute, then the patient must generate 2 liters per minute to receive a breath. So, or if it's a pressure trigger and it's set at -2 centimeters of water pressure, then they have to generate a negative amount, so pull in -2 centimeters of water pressure from baseline to receive a breath. Typically, flow triggering is the way to go. It's faster, it's a bit more sensitive, and it's a lot more easier for the patient so that we're not increasing their work of breathing and causing ventilator asynchrony with an improper sensitivity setting. So you want to pay attention to your patient, pay attention to your graphics, make sure that every time a patient tries to initiate a breath, they're getting a breath, that it doesn't look like the patient's trying to take a breath in and then they're not receiving a breath. We're inadvertently increasing their work of breathing and increasing the amount of time that they're going to be on the ventilator if we have an improper sensitivity setting. Normal settings are somewhere in around 2 liters per minute for flow or -2 centimeters of water pressure for pressure sensitivity. Some ventilators only have flow triggering, so it's best to know your ventilator and know what kind of sensitivity settings you have. So next would be humidification. That's the next thing that we're going to consider. So a humidification system is needed for all patients who have an artificial airway in place. We're bypassing their upper airway now, and that's our body's normal humidification center. So we're going to go and we're taking that away. So we have to add some source of humidification to the circuit and to the airway. So it's either passive humidification through a heat moisture exchanger or a Paul filter, or active humidification through a separate humidification unit, external heated humidity, where we can control the temperature. So the use of a heater with a temperature readout and a temperature alarm. So how do we determine which one we use, right? Do we use an HME or do we use the active humidity with the use of a heater? So here are some things to help you. These are some contraindications for a heat moisture exchanger. So if a patient has thick, copious, or bloody secretions, you're going to want to use active humidity. If their exhaled tidal volume is less than 70% of their inhaled tidal volume, so if they have some sort of a leak, then you're going to want to use active humidity instead of an HME. Remember, heat moisture exchangers only work by the exhaled gas trapping within that heat moisture exchanger and then heating up the new inhaled gas. So if a patient's body temperature is less than 32 degrees Celsius, we're going to want to use active humidity. If their spontaneous minute ventilation is greater than 10 liters per minute, we're going to want to use active humidity. We may overwhelm the HME when we're using tidal volumes that large. minute ventilation is that large. If a patient's on non-invasive ventilation, we'll use active humidity. And then if we have to give some sort of aerosolized medication into the system through the ventilator circuit, then it's going to get trapped in the HME. So it's not really appropriate for this patient, and we would have to use active humidity for that patient. So now we'll look at selecting the right mode of ventilation and which mode of ventilation you may want to use for a patient. And really this can be challenging, even for people who are experienced. There are a lot of things that we need to consider. You want to consider why they require mechanical ventilation. Does the ventilation problem require a special mode of ventilation? What are the treatment goals for the patient? Does a patient need an artificial airway, or can it be done non-invasively with a mask? Are they going to be ventilated in the intensive care unit, or are they going to be ventilated long-term or short-term? How long of the support? Are they going to require the support? And really, how familiar are the staff with the ventilator and the mode? But the basics of selecting a mode of ventilation, all modes kind of come down. Are they sort of pressure-oriented ventilation, or are they sort of volume-oriented ventilation? So when we look at the options for volume-controlled or pressure-controlled ventilation, our modes are sort of control and assisted, and really most modes are an assist control mode or a completely spontaneous mode of ventilation. And when we talk about control, or when you see control in a mode of ventilation, when you see that word, I want you to think that this parameter is what's set, and the ventilator will maintain that set parameter at all costs. And if a patient assists the breath, then this is patient-triggered breath, and they're going to receive a machine-controlled breath. We could also add on there a spontaneous breath. So a spontaneous breath is one that is patient-triggered and patient-controlled, but it may also be assisted a little bit by the ventilator. So in the case of pressure support ventilation, for example, the patient triggers all of the breaths. There's no set respiratory rate. They're triggering everything. They're controlling everything. But you can dial in a little bit of support, and the ventilator can support the patient through that breath as required. So first we'll look at volume control ventilation. And again, when we see that control, that is the parameter that's going to be in control of the ventilator, and the ventilator is going to try to maintain this parameter at all costs. So here we set a tidal volume. The tidal volume is set by the clinician, and pressure will change based on the patient's lung characteristics. So for example, if a patient has increased airway resistance, then to receive that tidal volume that's set by the ventilator, they're going to have increased airway pressures to overcome that resistance. So that's the important thing to remember about volume control. If lung compliance decreases, so now we need more pressure to get that same tidal volume, then our pressure is going to increase if our lung compliance decreases and our tidal volume is staying the same. So when we see these increases in peak pressure, looking at our patient who's on a ventilator in a volume control mode, we can kind of understand that a couple of different things have happened. So maybe there's an increase in airway resistance, or there's a decrease in lung compliance, but something has caused this pressure to increase. Maybe there's some sort of obstruction that's occurring, secretions, something like that, and it gives us an idea, gives us the tools that we need to go and figure out and determine sort of what the root cause is. So with volume control ventilation, each breath is either assisted or controlled, and it's going to deliver a preset mechanical tidal volume. So the breaths will be triggered either by the patient. Again, they'll use pressure or flow to trigger those breaths, or they could also be time triggered. So if a patient doesn't have a drive to breathe and they're not initiating any breaths, then time will be that factor based on their respiratory rate. If their respiratory rate is 12 breaths per minute, then every 5 seconds the machine is going to deliver a breath. And the cycling mechanism, so really what's going to end this breath, will be volume or time cycled. So once a preset volume is reached, or once a preset time is reached, depending upon the ventilator and what is set on that ventilator. Now, pressure control ventilation. With pressure control ventilation, we're looking at the difference between baseline pressure, so your PEEP and your auto PEEP if there is any, and the set inspiratory pressure, and that's what's going to determine our tidal volume. So So we're going to set a sort of peak inspiratory pressure, and the ventilator is going to deliver that pressure on every breath. So all breaths are time triggered or patient triggered, and we're targeting a pressure. So lung characteristics will change the volume that's delivered. Because the pressure will not change on every breath, it's going to be what we set. We're controlling pressure in pressure control ventilation. So I say, I want the peak inspiratory pressure to be 25 centimeters of water pressure during this breath. Then I'll dial in 25 centimeters of water pressure, and the ventilator will deliver 25 centimeters of water pressure on every breath. If a patient's lung characteristics change, so for example, if their airway resistance increases, then I can't increase my pressure to deliver that same tidal volume because my pressure is controlled on every breath. I'm still going to keep delivering that 25 centimeters of water pressure, and what's going to happen is I'm going to get a decreased tidal volume in that case of increased airway resistance. The same would happen if our lung compliance decreased. So we're ventilating along, 25 centimeters of water pressure, our lung compliance decreases. Now what's going to happen is our tidal volume will decrease as our lung compliance decreases if we do not change the amount of pressure that we're delivering in pressure control ventilation. So this is a good little picture here. We can see it's time cycled. So we're setting an inspiratory time, and what happens is the ventilator goes up to that pressure, and in this case here, that pressure is 15 centimeters of water pressure. So we start at our baseline, we increase up our 15 centimeters of water pressure, we stay there for the set amount of time, the breath ends here, and we enter into exhalation. This mode is really good if you want to control the pressures. Obviously it's pressure control ventilation, but if we're worried that we're using very high airway pressures and we want to make sure that we're not causing any overdistension, we're not causing any barotrauma in the lungs, we can maintain, we know that the pressure in the lungs isn't going to go any higher than what we set. This is why we would use this mode of ventilation. So when we're looking at pressure control ventilation, the types of breath, we have mandatory breaths that are available to the patient in pressure control mode. They can both be controlled and assisted, so they can be patient triggered by pressure or flow, or they can be time triggered based on the respiratory rate. And really the primary cycle mechanism here is time, okay? So we set an I time, an inspiratory time, and after a certain amount of time, then the breath will end. There is a pressure cycle as a safety. In all modes of ventilation, we have a pressure cycle as a safety. So if our high pressure limit is exceeded in any mode of ventilation, then that is what's going to end the breath. So when it comes to setting our pressure, right, we need to determine what pressure to set to get our desired tidal volume. Getting a desired tidal volume is really easy. In volume control ventilation, you just dial in what the number is that you want. If you say, I want a tidal volume of 450 mils, you put that in, and the ventilator is going to deliver 450 mils on every breath with varying degrees of pressure. With pressure control ventilation, it's a little bit more difficult. So there are a couple different methods that we could use to determine, to set the pressure in an appropriate way to achieve our desired tidal volume. The first method is we set a volume in volume ventilation. So we put the patient into volume control ventilation and we set our tidal volume and we determine what our plateau pressure is. So we're in volume ventilation, we do an inspiratory hold and we determine what our plateau pressure is. The next thing we're going to do is we're going to do an expiratory hold as well to determine what our total PEEP in the system is, and then we take the difference between the two. So we take our plateau pressure and we subtract our PEEP, and really that's indicative of, from our baseline pressure to what our plateau pressure is, that pressure difference between the two, that's indicating what the alveolar pressure is, so how much pressure is in the lungs for that set volume that we inputted in volume control. So for example, if it's 450 mils and my plateau pressure minus my PEEP is 20 centimeters of water pressure, then it takes 20 centimeters of water pressure to inflate the lungs to 450 mils, to have 450 mils of volume within our lungs. So it's a good way to have an initial pressure setting to deliver on the ventilator so that we can achieve what tidal volume we would like to have. So you will then switch the patient over to pressure control ventilation, dial in whatever number it is, that delta P between plateau and PEEP, and look at your tidal volume and adjust as necessary to make sure that you're achieving the desired tidal volume that you want. There is another method which is a little bit less accurate. Here you would put the patient on pressure control ventilation, start at a lower pressure around 10 to 15 centimeters of water pressure, and then gradually titrate your pressure until you're at the desired tidal volume. There is a bit of a disadvantage to using this method. You may have an increase in alveolar derecruitment when we're using this method, but you can do this sort of initially. It's something that you can do straight away, starting off without having to put your patient into volume control mode first and determining that plateau and PEEP. The next mode we'll talk about is synchronized intermittent mandatory ventilation. And really, SIMV is here to deliver, you can either deliver a set volume or set pressure breaths the way that you would in volume control or pressure control. They're time triggered. They're going to be, there's a minimum frequency, so there's a minimum rate that you're going to set, the SIMV rate, and the patient's going to get all of those breaths. So if you're in SIMV mode and you have a respiratory rate set of 12, then in 1 minute, they're going to get 12 machine-delivered breaths, whatever they are, depending upon what you have set. So if you have it in pressure control ventilation, then they're going to get 12 of those machine-delivered pressure control breaths. If you're in volume ventilation, they're going to get 12 of those machine-delivered volume control breaths. What's different about SIMV than pressure control or volume control is that any breaths in between that the patient triggers, those are going to be spontaneous breaths. So that's going to be either all patient, if you're not giving any support, or little pressure supported breaths that are spontaneous. So not the machine preset breaths in between those breaths. This picture is really good here. It shows us spontaneous ventilation and what those spontaneous breaths look like. And what's happening with SIMV is here's our machine delivered breath. So we have a rate that's set, and we know that we're going to deliver 10 breaths a minute of these machine delivered breaths. So any other breaths that the patient wants to breathe are these little spontaneous breaths in between. Now you can note that these breaths may be pressure supported if you choose. Then a window is going to open up. So at some point in time, the machine's going to say, I need to deliver another mandatory breath. I have to deliver so many in a minute, and that needs to occur soon. So it opens up a little window. And if the patient happens to trigger a breath during that window that's opened up where they need to have their mandatory breath, then that's what they're going to get. So it's going to synchronize with the patient effort. If that window goes by and the patient does not initiate any breath during that period of time, then the machine says, oh, they're not breathing, I'm going to deliver that breath anyway. So again, you're always going to get that guaranteed rate. Whatever that synchronized rate is that you set up for that patient, whether it's 10 breaths per minute, 12 breaths per minute, 15 breaths per minute, they're going to get that. Anything else in between that set rate is going to be a spontaneous breath that's delivered, controlled by the patient, that is possibly supported if you choose to pressure support those breaths. So when we look at SIMV, each breath is assisted or controlled, and it's going to deliver a preset mechanical tidal volume or a preset pressure, depending upon which mode you're in. The patient can breathe spontaneously in between breaths, and those breaths may be pressure supported. Triggering is the same. It's either pressure or flow when they're patient triggered, or if the patient is not making any efforts on their own, then we default back to that set SIMV respiratory rate, and the breaths will be time triggered based on that set SIMV respiratory rate. How those breaths are ended, they're going to be volume or time cycled if it's volume ventilation, or time cycled if it's pressure ventilation. So it will depend on what your primary mode of ventilation is in SIMV, whether your preset breaths are volume, or pressure. This mode of ventilation can be used as a weaning mode. So we start off delivering a larger number of mandatory breaths, and then you start decreasing that number of mandatory breaths, allowing the patient to do more spontaneous breathing and to build up those muscles of respiration and help to get them ready to be removed from the ventilator. Next, we'll talk about pressure support ventilation, or PSV. And PSV is a completely spontaneous mode of ventilation. So this is important to note that with pressure support ventilation, we are now letting the patient control all of the parts of breathing, and we're adding a little bit of pressure to help to support their work of breathing. So to help them overcome the resistance of that artificial airway, and then any other little bit of assistance that they may require. Now, in this mode of ventilation, it's purely spontaneous. A patient must have a drive to breathe. There is an apnea time, like a backup ventilation that is set, that if a patient doesn't breathe for a certain period of time, whatever that apnea time is that you set, then this backup mode of ventilation will kick in and the ventilator will start delivering breaths timed based on whatever mode you have set as a backup mode. So we're not setting a respiratory rate in pressure support ventilation. This is all the patient. They need this drive to breathe. So this is a purely spontaneous mode of ventilation, and really we're helping them, we're assisting them with the breaths that they take to help any sort of increased work of breathing that they may have. So how do we set a pressure support ventilation? What's the best way to do this? So again, if we're in volume ventilation, then we can determine the trans airway pressure. So take your PIP minus your plateau, do an inspiratory hold and figure out your plateau. The difference between your PIP and plateau is a good starting point. That's really the resistance that the patient has in the airway. So now you're setting a support, a bit of pressure support to overcome that resistance of the airway. So that's sort of the minimum amount of pressure support that a patient will need. The resistance could be imposed by an artificial airway, the ventilator circuit, valves, or their own resistance themselves. So it's a really good starting point. The goal of pressure support ventilation is to have their tidal volume somewhere in the normal range, somewhere between 5 and 10 mils per kilo, with 5 to 8 being, the best sort of range for the patient. We want to make sure that they're decrease their respiratory rate, so somewhere less than 25 to 30, depending upon their pathology. The minimum setting of pressure support is going to aid to overcome the imposed work of breathing because of the tubing and the circuitry and all that resistance that's associated with it. So if we're just delivering enough pressure to overcome the resistance of the endotracheal tube, then really all of that tidal volume that the patient's receiving, that's them doing the work. And this is a great mode to wean patients. So we put them into pressure support ventilation, make them do more of the work of breathing, so that we can remove them from the ventilator. And when we remove them from the ventilator, we know that they're going to be able to maintain their ventilation on their own. There is a setting, sort of a pressure support max. That's the term for the pressure set so that it's high enough to provide a tidal volume of 5 to 10 mils per kilo. It can vary based on the patient. If you're delivering really, really high support modes, so if you're into to higher levels of pressure support, that's sort of the max amount. And now we're not just overcoming the resistance of the endotracheal tube and the circuitry, we're actually aiding the patient. We're taking away some of that work of breathing now. So we're helping deliver that volume that we're hoping that they can achieve on their own. So here in pressure support mode, it's a little bit different how we switch from inspiration to expiration. If we look here on the top, we're in pressure control ventilation. And pressure control ventilation will time cycle. So we set an inspiratory time, and when that inspiratory time runs out, then we cycle from inspiration into expiration. It's a little bit different in pressure support. The patient's controlling a little bit more. So here they're triggering the breath on their own. As you can see, the machine is delivering a certain amount of support. And when the flow that normally slows down, so remember how ventilation works and how our lungs fill and how the pressure gradients work. We're ventilating at a constant pressure at the mouth, so this is our mouth pressure, and this is as our alveoli fill with volume and the pressure increases in our alveoli, that pressure gradient between the mouth and the alveolus, which was once quite large right here, starts to slow down. The pressure gradient gets smaller, and as the pressure gradient gets smaller, flow starts to slow down. So we have this natural flow decay as the breath continues and pressure stays the same at the mouth and the alveoli fill. So how pressure support ends, we need something to tell the ventilator, hey, we're done inspiration, we need to go into exhalation. And how that works is by flow decay. So once the flow reaches a certain percentage of peak flow, then the ventilator will stop delivering pressure and will switch over into exhalation. And this is a parameter that we can set. So we can set what that flow cycle is. We can say, hey ventilator, when our flow reaches 25% of our peak flow, this is when then it's low enough, we're going to stop inspiration and we're going to switch to exhalation. So that's a parameter that you can set on the ventilator, and you may need to change it for a number of different reasons. If a patient starts to double trigger and breath stack, if you think that they're not they want out of the breath prior to the ventilator ending the breath, then you may want to change that setting. Or if you think that they need more volume, that they want that breath for a longer period of time, then again you may have to adjust that setting accordingly. So when we look at pressure support ventilation, when we look at the type of breath in pressure support ventilation, all of the breaths are pressure supported and they're considered spontaneous breaths. So they're triggered by the patient and the patient controls all aspects of the breath. The ventilator is just giving a little bit of assistance based on what level of support you add, what you're controlling there. The trigger mechanism, all patient, okay? So pressure or flow, depending upon what's set. There's no time triggering here, right? This is a completely spontaneous mode of ventilation. We're not setting a respiratory rate. So patients are triggering all of the breaths. And how the breaths end, so their cycling mechanism, it's primarily cycled due to decay and inspiratory flow to a predetermined level. There are safety features, sort of backup features of time and pressure in case of increased time constants, leaks, or that patient who actively exhales against the inspiratory flow. So if the pressure increases in the system, or if it goes on for too long, if inspiration goes on for too long, the ventilator has some predetermined settings and it will end the breath at that point and cycle into exhalation. Pressure support is primarily used in weaning patients. When we're talking about doing a spontaneous breathing trial, so something that we like to do on patients every day and something that we would do on patients prior to extubating them, we're going to use pressure support ventilation as the mode for a spontaneous breathing trial. So typically it's some sort of minimum pressure support, anywhere between 0 to maybe 8 centimeters of water pressure for support, a normal level of PEEP, and we put the patient into the supported mode with the determined amount of support that's required, and we see how they do. We see how they breathe. And if they're able to maintain sort of normal parameters, then we may consider, yes, now it's time that we can liberate this patient from the ventilator. Now we'll look at what we like to call a dual mode of ventilation. It may be called PRVC, or pressure regulated volume control. It could be called VC plus, or autoflow, or pressure control with a volume guarantee, depending upon what ventilator manufacturer you're using. So there are many different terms for this mode of ventilation, but essentially it's a mode of ventilation that provides closed-loop pressure breaths to achieve a set tidal volume. So really it's kind of a smart pressure control. You're delivering pressure-controlled breaths, so maintaining a constant pressure throughout the breath. So because we're maintaining that same pressure throughout the breath, it's a bit more comfortable for the patient. It works the same way as pressure control does, that we have this sort of constant pressure throughout the breath. So pressure is constant, like so. And then we have this nice flow decay that occurs. And that's a bit more comfortable for the patient than volume control ventilation, where we have this sort of increasing pressure gradient throughout the breath and a kind of a constant flow. So having that constant flow throughout a breath isn't very comfortable. However, with pressure control ventilation, we're not getting a guaranteed tidal volume on a breath-by-breath basis, right? Anytime lung characteristics change, that tidal volume is going to suffer. It's going to increase or decrease based on those changing lung characteristics. Where with volume control ventilation, we have that nice set tidal volume that we get on every breath. We sort of have a good guaranteed minute ventilation that we're getting on every breath. And the best way to control our blood gases is to control our minute ventilation. So volume control mode is really best for that, but pressure control mode is really more comfortable for the patient. So now with this dual mode of ventilation, we get these nice pressure breaths here. So the breaths look like this. We're delivering that pressure throughout the breath, but we're going to target a volume. So we're going to set a volume and target that volume. So it's kind of a smart pressure control. So it uses closed loop communication on a breath by breath basis. It will set its tidal, it will change, its pressure on a breath by breath basis to achieve and get close to a set tidal volume. So it's a commonly used form of ventilation in both the pediatric and the adult population because it's a bit more comfortable for the patients, and we can get a sort of guaranteed minute volume as best we can to keep our blood gases nice and stable. So it's a form of assist control ventilation where a breath can be initiated by the ventilator or by the patient. We're going to set a respiratory rate, we're going to set an I time, we're going to set a tidal volume, we're going to set a PEEP and an FiO2, and we're going to set a sensitivity setting, right? So there can be patient triggered or they can be ventilator triggered. So again, we're looking at the settings that we want. We're going to want to have a minimum respiratory rate, but the patient can always trigger a breath if they want to. We're going to have a target tidal volume set. We're going to have an FiO2 set, a PEEP set, a rise time, and then an inspiratory time that's set. The goal here is to set a decent expiratory time, like I mentioned at the beginning of this lecture, so that we have enough time for exhalation based on what our total cycle time is based on our respiratory rate, to maintain a nice 1 to 3, 1 to 4 IE ratio if possible. So how does it do it? How does it work? So once you enter the desired settings and the patient's connected to the ventilator, it uses a test breath. It uses one initial test breath, that first test breath. That's a volume controlled breath, and it determines the plateau pressure. And like pressure control ventilation, where we use the difference between our plateau and our baseline, so that delta P here, that's what it does. So it determines the plateau pressure and it knows the baseline pressure, and it uses that delta P as its initial starting breath. And then over a 3 breath period, it's hopefully reached its target volume. Its goal is to reach its target volume. So the ventilator, the next breath will be delivered on the ventilator will be here, and then it sees what volume that is, and it says, hey, is this close to what my set volume is? If it is, great, then we're going to continue on at that pressure. If it's not, if it's below what the set volume is, then on the next breath, it's going to increase the pressure. And then again, it goes back to the ventilator, and the ventilator will assess that tidal volume that returns back to the ventilator, and it will say, hey, do I need to increase my pressure, or can I stay the same, or do I have to decrease my pressure? So if we look here, this is a screenshot of the servo eye. We can see that first breath is that volume breath, and there's our plateau here, and our baseline pressure here. So the next subsequent breath starts where that plateau is, and it's analyzing it. The ventilator's analyzing it, and it's saying, is my volume the same as the volume that I want it to be? Well, it's not quite there. It's a little bit lower. As you can see, it's not quite the same. So on the next breath, on the next subsequent breath up here, it's increased. It's gone up a little bit. And again, we're going to compare this volume to what my set volume is of 400 mils. And if this pressure is good, then it's going to continue ventilating at that pressure as needed, and it's assessing the exhaled volume here on a breath by breath basis to make sure that it's going to deliver as close as it can to that set tidal volume that you've inputted in the machine. So this mode is a really versatile sort of mode. It's a good mode for the patients and for clinicians, because again, like I said, it's a bit more comfortable for the patients, and we're able to control our minute ventilation a little bit better, and we can be a little bit more precise when we're making any changes to the ventilator based on our blood gases to optimize our blood gases in the best way that we possibly can. So great mode to use in that sort of situation. Next, we'll look at bi-level positive pressure ventilation, or bi-level pressure assist, or BiPAP. It comes in a lot of different names. Okay, so now we're really looking at a sort of non-invasive mode of ventilation here. And it's similar to CPAP, that's just providing sort of continuous positive airway pressure. But now we have positive airway pressure on expiration, and we've added some positive airway pressure on inspiration. So we provide an inspiratory positive airway pressure, which is set at a higher pressure than our expiratory positive airway pressure. So if this is our PEEP and we're patients breathing along, and this is our CPAP, then when they take a breath, the pressure increases to whatever we have set for our IPAP, and then when they're done taking a breath, it stops, and they continue along at their regular CPAP level. They take a breath in, the pressure increases, and it continues along, so that we have our EPAP here. Sorry, it's a terrible E. And then our IPAP, our inspiratory pressure, sort of up here. So it's seen a lot non-invasively, sort of non-invasive ventilation. It really depends on the type of ventilator that you're using, sort of what kind of pressures that you're going to set. The basics that you have for this sort of mode of ventilation is you're going to have some sort of end expiratory airway pressure and some sort of inspiratory airway pressure, whether that's called IPAP or EPAP, whether it's called PEEP and pressure support. They're going to do the same thing in the end. You just have to be wary of what you're setting and how those settings work. So for example, if I'm setting a PEEP and a pressure support, then I have a nice baseline pressure, and whatever I set for a pressure support is going to be above that baseline pressure. So if I've got a pressure support of 5, and then if I have a PEEP of 5 and I have a pressure support of 5, then the total pressure in my system on inspiration is going to be 10. If it's labeled EPAP and IPAP, a lot of the time you have that EPAP, that end expiratory positive pressure, so if that's set at 5, and then I would set my EPAP above that, or sorry, my IPAP above that. So if I set my IPAP at 15, for example, I've got a baseline pressure of 5, and then on inspiration it's going to jump up to 15, and the amount of support is the difference between the two. So the amount of support here in this situation would be 10 centimeters of water pressure. If I was to increase my PEEP in this situation, if I'm to increase my EPAP, well, my IPAP is still staying the same at 15. I haven't changed that. So now my EPAP is up to 10, my IPAP is at 15. So my baseline's at 10, and I'm breathing along at my baseline of 10, and then I take a breath in, and it jumps up to 15. So that delta P has changed now. That difference between the two has gotten smaller, so my amount of support has gotten smaller. It's just good to know how your ventilator works, and whether you're going to be adjusting a support or if you're going to be adjusting an inspiratory pressure and an expiratory pressure, so that you don't make any errors and cause your patient to have changes within their ventilatory status. So if we're looking at this sort of situation, that difference between your inspiratory pressure and your expiratory pressure, that change, that delta P, that's really going to affect ventilation. So if you have a patient and you're trying to remove more CO2, we want that to be a little bit larger, a little bit bigger, and if we're changing our baseline pressure and it's not going to change and it ends up changing our level of support, then that may be detrimental to the patient. So I just caution you to understand, to look at the ventilator that you have at your facility and what ventilator you would be using with this mode and how this mode works, and understand if you're setting a support level and a PEEP, or if you're going to set a PEEP and a peak inspiratory pressure, and what happens if you change one, if one changes. If your PEEP changes, does your support change, or does your peak inspiratory pressure change, and how they change. And then lastly, we'll talk a little about airway pressure release ventilation, so APRV. Here, it's honestly, it's sort of an extreme inverse ratio ventilation. So now we're spending more time in inspiration than we are in expiration. And it does allow unrestricted spontaneous breathing at 2 different levels of pressure. So the way this mode works is we have a high pressure and a low pressure, and we spend a certain amount of time at our high pressure and a certain amount of time at our low pressure, and the patient can spontaneously breathe at any time during the cycle. When we're looking at APRV and the settings that we use in this mode of ventilation, one of the first settings that we'll use is a high pressure, or P high. And so this is sort of the, again, like I say, you breathe along at 2 different pressures. You have a high pressure and a low pressure. And this, in the inverse ratio sort of portion of this mode of ventilation, we're going to spend more time here in this high pressure. So how do we determine what high pressure we're using? If the patient's in pressure control ventilation prior to entering this mode of ventilation, then you're going to set your pressure high at the inspiratory pressure level you were using in pressure control ventilation. If a patient was in volume control ventilation prior to entering this mode of ventilation, then you'll do a plateau maneuver, so an inspiratory hold maneuver. Figure out what your plateau pressure is and use that as your P high setting for APRV. And then if you had a patient who was in high frequency oscillation ventilation, prior to going into APRV, then you would use the mean airway pressure as the initial start for your pressure high, your P high. When setting our P low, you can set it really anywhere below your P high, but typically what you want to do is set it at 0 or close to 0, so that you have a large pressure gradient between your high pressure and your low pressure, so that when we switch off of your high pressure and we go to our low pressure, we have a very large pressure gradient. We release, again, it's airway pressure release ventilation, we release that high pressure, have a large gradient so that we can exhale a large amount of gas, right? So we can create a very large pressure gradient so that we can exhale the gas for a short period of time before going back up to that high pressure and staying there. So typically we set this pressure at 0, and the goal really is to set your T low, your time at that low pressure very, very short, so that we're creating some auto PEEP and we are never reaching a 0 flow, okay? So we're actually never reaching that 0 baseline pressure. That's sort of the whole goal, is to have our time so short that the patient, when they're exhaling, when that pressure is released and they're in sort of that kind of quote-unquote exhalation phase, when they go from high pressure to low pressure and dump their CO2 out, that they never actually reach that 0 baseline, and then they're gone right back up to sort of that high pressure. So if we're looking at it, it would kind of look like this. We're going up to our high pressure, and we're going down to our low pressure, and then right back up to our high pressure again. And let's say this is our 0, it's not very straight, but this is our 0 baseline, and we're never actually reaching that 0 baseline before we go back up to our high pressure. Our time at high, anywhere between 4 to 6 seconds for adults, and really you want it to be 90% of your total cycle time. You're not setting a respiratory rate in this mode. It is a spontaneous mode of ventilation. You're determining what your respiratory rate is based on adding your time at high. Consider that your inspiratory time, your time at low, your expiratory time. So add those two numbers together and divide that into 60, and that's what's going to determine your respiratory rate, quote unquote. So really you want your time at high to be 90% of that total cycle time. So most of our time is spent at that higher pressure, and a very small portion of the time is spent at that lower pressure. Again, we want to avoid reaching a zero pressure baseline. We don't want to get all the way down to zero. We typically just set our low pressure at zero so we can have a very large pressure gradient to remove as much gas and as much CO2 as possible before jumping back up to that high pressure. So if you look here, the importance of time. So this is our time, this is our CPAP phase here. So this is our time at high pressure, and you can see that at any point during the cycle, the patient can breathe on their own. These are those spontaneous breaths. So APRV uses time to maximize lung recruitment. So you're essentially going up to this nice high pressure, recruiting all kinds of alveoli, staying at that high pressure, allowing the patient to spontaneously breathe if they want to, maximizing our surface area for gas exchange, and then every so often releasing that CPAP so that we can dump out CO2 and then go back up to that high pressure again, re-recruit all those alveoli, and maintain that nice large surface area for gas exchange. Your release phase down here, minimal amount of time. Really, you don't want this long time like I have here in this picture. This would be too long. We don't want to reach a zero baseline. The goal is never to be at zero, because if we're at zero, then chances are we're probably going to de-recruit, right? So minimal amount of time spent at a lower pressure to prevent de-recruitment of alveoli, and then we jump right back up to that higher pressure. The only reason why we're releasing the pressure and we're dropping down to that low pressure is so that we can release some of the CO2, so we can release some gas, wash out that CO2 before jumping back up to that higher pressure, that higher CPAP level. This really isn't a mode of ventilation that we're using for every patient. There's studies are out there. The typical patient that you're probably going to see this on is your ARDS patient, or somebody with ventilator-induced lung injury for whatever reason, and they have refractory hypoxemia, they have higher oxygenation requirements. So we're going to use this mode of ventilation to maximize the amount of time that we're spending at these high pressure levels, to maximize the amount of surface area that we're having to recruit alveoli to help improve our gas exchange. So that's it for this information session. I will say this is not an exhaustive list of modes of ventilation by any stretch of the imagination, and it's also not an exhaustive amount of information for each mode of ventilation. It was just sort of a quick overview of a few handful of common modes of ventilation that we use, and the types of settings that you may be required to set on these modes of ventilation, and just some basic initial settings that are good for these modes of ventilation. So I want to thank you for listening, for tuning in, and thank you to the Canadian Society of Respiratory Therapists, and I will see you next time.